Thank you, Dave, for that introduction. While they're sitting here, I take the opportunity to, I want to thank the organizers of RAMSES 2015 for putting together such an outstanding academic program. Sijo, Jesse, Philippe, and a big thanks to Georges for inviting us to this very welcoming city, extremely modern and beautiful Geneva. We're having a great time here. Today, I'll be talking to you all in the next 15-20 minutes about some of the new or novel applications or technologies that we have implemented in our practice for minimal invasive thoracic surgery. Some of these have changed and revolutionized what we're doing in the field of anesthesia. As you can see there, and I'll show you and I'll take you, so some of the most important things which apply also to plastic surgery and many other procedures that you do robotically is the precise management of perioperative fluid administration. We no longer use arterial lines, which, as you very well know, an arterial pressure only gives you pressure, and pressure is not a good surrogate of perfusion. We're looking more at non-invasive hemodynamic monitoring technology that gives us bit-to-bit information about fundamental parameters of flow, such as the cardiac output, and to me, very important, the delivery of oxygen to the tissues, and the most important tissue where you, the surgeons, are operating. That's fundamental for us to know that. Then I'll move a little bit into our enhanced recovery after thoracic surgery initiative. Dr. David Rice and I are leading that at MD Anderson, and some of the things that we're doing to mitigate the inflammatory response, diminish the use of opioids, almost abolish the use of opioids because they have deleterious side effects, not only on the patient, but also on oncologic patients or on animals. We've been demonstrated the effect, the negative effect of the immune system, such as the natural killer cells. And I'll talk a little bit about what we use for immune regulation, some specific blocks that we're using with unique novel pharmacologic agents that allow us to minimize the use of opioids, use of multimodal analgesia, and many other things that have really revolutionized our practice. This is our medical center in Houston, Texas, considered by many the mecca of the medicine in the world. Certainly, for sure, the biggest, but everything is big in Texas, as you guys know. But this is what is in pink. It's kind of the MD Anderson buildings. We have the largest congregation of Da Vinci robotic units in the world, with 30 of them in the medical center. 4 at MD Anderson, constantly being used. We have a high volume oncologic center. We perform about 300 minimally invasive thoracic surgeries, including pulmonary and esophageal, and out of these, 20% are specifically robotic. The number 20% is because the only surgeon is Dr. Rice actually using the robot for thoracic surgery. So you understand the importance of fluid administration, to be precise, again, not only for esophageal surgery, but where it's important because part of the surgery needs to be, you're restrictive in the thoracic part and you want to be a little bit more liberal in the abdominal aspect, but it applies to any surgery in microvascular surgery as well. And it is not the endothelium, but really the glycocalyx, the real molecular filter. This membrane was not known by Frank Starling. That's why I believe his principles should be revised and updated, because this is the real molecular filter maintaining the plasmatic proteins and the oncologic pressure within the vascular lumen. Chappelle and co-workers clearly demonstrated in this, you can see micron electroscopy picture on the left upper corner, the harmonic architecture, the elegance, intimacy between the glycocalyx and the vascular lumen. And at a closer view, magnification, these glycoproteins are really the ones that maintain that tight endothelium throughout the surgery. What happens in the bottom images is a total destruction of this architecture that leads to interstitial edema. At a microcellular level, what happens is that the oxygen, the distance that it's traveling from the vascular lumen to the cell increases, and obviously that leads to cellular hypoxemia, cellular death, apoptosis, and that's at a microcellular level. But what we see clinically is perhaps one of your flaps, that unexpected failure after a perfect surgical technique. The same thing with an perfect esophageal robotic surgery where you have anastomosis of the leak. These are the things that surgeons do not find the reason, and I'm pretty sure we are guilty of that in the anesthesia field. So what happens, there are 3 things that cause this destruction. One is surgical trauma, which obviously we cannot do anything about it. That depends on you, the surgeons, which has been improving lately with minimal invasive surgery. And from our side, obviously, the poor administration of fluids or over-administration both cause the same exact damage and destruction on this membrane. Once the damage is done, by the time you try to correct it, it's too late. What happens is obviously a massive inflammatory response with release of mediators, cytokines, complement coagulation factors, a very prothrombotic state in a very high-risk surgical patient that has been associated in the literature to increasing morbidity and mortality of, after surgery. This is a recent paper, 2005, American Journal of Surgery, the impact of fluid resuscitation on major adverse events following Whipple procedures. This is a follow-up for 10 years. You can see the very high incidence of leak, 42%, sepsis 17%, cardiac failure 7%. What they found is that patients who had a positive fluid balance on days 0, 1, and 2 were more related to adverse effects, including transportation to the ICU and increasing the length of stay. But what to me was more striking is that the patients who had a positive balance on day 0 were more strongly associated with post-op morbidity. And that doesn't depend on, you guys know, on surgical mobilization of fluids. That depends on us in the operating room. That's why we're so obsessive about precise fluid management, at least at MD Anderson. And what we do, as you can think about it in thoracic surgery, the goal, the traditional, was to keep the patient very dry for minimally invasive surgery, because your patient is going to have a right thoracotomy. So the concern was that if you give too much fluids, then you have edema of the contralateral lung. So that can be devastating, a devastating complication. We don't do that anymore. You can see that figure here in the left bottom corner. This is the x-axis is the volume status of the patient. The y-axis is morbidity. As you move away from this perfect state of normal homeostasis, of perfect euvolemia, you have a marked increase in morbidity. If you hypo-administer fluids, obviously you get gastric hypoperfusion, translocation of bacteria, sepsis, acute renal failure, cardiac ischemia, and so on. And if you over-administer fluids, you obviously have what we see in pulmonary edema, anastomotic leak, postoperative nausea and vomiting, and ileus. So how do we keep our patients in the precise, perfect state of euvolemia, knowing that the blood pressure, the CVP, the pulmonary artery occlusion pressure are very poorly sensitive indicators to let us know which patient is going to respond or not to a fluid challenge, or where is the patient sitting on the Frank-Starling curve. We use now technology, very novel technology, is non-invasive, 2-finger cuffs, gives you bit-to-bit information about parameters of flow. You can see actually the heart-lung interaction, where you can have important flow data such as the cardiac index, the stroke volume variation, and it tells you exactly, sometimes helps you with the delivery of oxygen to, again, it's important for me to know exactly what is the oxygenation at the level where Dr. Rice is doing the esophageal anastomosis. So we know exactly where is the patient in the Frank-Starling curve, put them in the sweet spot, and when we know when to push the pedal to the metal, or just when to hit the brakes with the administration of fluids. This is an example of what we do. We use a non-conservative, non-liberal approach, non-invasive technology. This is a patient position for a right robotic lobectomy. No more arterial lines. I know how you guys, surgeons, hate our lines and the time it takes for many anesthesiologists to put them. We don't need that. A line only gives you pressure. We do not use that anymore in our practice. And what this technology allows you is to very early detect where is the harm, how to early attack and prevent further derangement in the cardiovascular system. This is an interesting study by a friend of mine and ex-president of the European Society of Critical Care. And to me, this is striking because this will give you a little example of how do you communicate your anesthesiologist and the importance of fluid administration and management. He had 53 patients which he implemented goal-directed fluid therapy and decided to follow them through a 15-year survival follow-up. He had a control group with 53 patients. Look what he found. The goal-directed therapy, more than 20% were still alive after 15 years. Less than 10% were alive in the control group. So a median increase in survival of more than 3 years. So he decided to then mix the groups to see account for complications. This is what he found. It's a small group, but very striking. Even if you didn't have any intraoperative or perioperative complications, still the patients with goal-directed therapy, fluid therapy, live longer. But this is what it was striking to me. If you allow a cardiac complication that happens all the time, when there is hypoperfusion or induction, you have ST segment changes, the damage is done. You can correct, raise the pressure, but the damage at the microcellular level, where you're gonna do your anastomosis, is already done. And renal, you have bump in the creatinine and these things, but look at these patients, they were all dead. 7 years, the curve continues to go for the goal-directed therapy. The guys who had a cardiac ischemia were dead, and the patient who had acute renal failure were all dead in 3 years. So that's why we have become very obsessive. I've given the authorization to develop these algorithms at MD Anderson to be used in all of our enhanced recovery initiatives. We have pretty much in every subspecialty. We're going to use these algorithms that I've designed based on scientific evidence, and we're working to see if we design closed volume loops to take away the equation of the anesthesiologist doing what they want and have these pumps give the fluids according to the hemodynamics and the physiologic changes that are happening through surgery. The other part, to switch gears, that I want to talk about is what we do right now in our ERADs, and dedicated to blunting mainly the stress response from surgery, the inflammatory response, and all of the decreasing the use of opioids, because they are very deleterious for cancer patients. Right now, the White House, as you know, President Obama 2 days ago was very instrumental on regulating the use, and they're going to be punishing physicians who prescribe narcotics, because we're very concerned about the high addiction in the United States. And we don't need to use much more narcotics with the things that we're using currently. If you do it appropriately, use them. So as you guys, surgeons, have evolved, we have obviously evolved. And Philippe, this is for you, that you think your anesthesiologist always bombards the patient with gases and morphine, and then goes drinks coffee. I think we have changed a little bit. We have evolved, and we're also working really close to the surgeons on multimodal analgesia, which is the use of several pharmacologic agents with different, attacking different receptors and working synergistically to decrease the consumption of opioids, and using unique blocks that I'm about to show you. But this is what happens in the perioperative period. X-axis is the time, Y-axis is the risk of micrometastasis. This is when the patient is most vulnerable to micrometastatic disease from a pro-angiogenic environment, tumor shedding from surgery, immune suppression, mainly from two things that if you guys tell your anesthesiologist they can get rid of, is the volatile agents that we don't even know how they still work in the brain. Why are we going to give our patients something that I don't even know how it works in the brain? The gases, and obviously the very bad opioids. Tissue factors release and inflammation. This is already being clearly demonstrated in the literature. The new opioid receptor promotes opioid and growth factor induced proliferation, migration, and epithelial mesenchymal transition in human lung cancer. This has been shown in many models. So we're trying to minimize that, because our whole goal is to accelerate patient functional recovery. This is what used to happen in the past. In traditional open thoracotomy, in the traditional care, the patient used to take several weeks to a functional recovery. Some of them need to come back for life-saving chemotherapy, and this time it's important. Now we've been able to shorten this time. Patients live sometimes 2 days after a robotic thoracic surgery. So imagine the acceleration of the functional recovery and the possibility one day of patients to come early to receive life-saving chemotherapy. This will be fascinating in the long term to look at mortality, long-term survival. What we do is bombard pain from every front, not using opioids, and actually, just to give you an idea of what we're using for a thoracotomy or minimally invasive thoracic or esophageal surgery, we're using doses that we use of opioids for a screening colonoscopy. It's 50 to 100 micrograms of fentanyl. That's all we give done at the induction. No more opioids. No, that's all is needed. But you need to do some things all together, and we start by giving the patients preoperatively, loading them with gabapentoids. This work presynaptically, blocking the entrance of calcium and the release of substance P and other pain mediators. We use tramadol, which you're familiar with, weak opioid, but also have very important effects on hydroxytryptamine reuptake and noradrenaline and other pain mediators. We use the non-steroidals and COX-2 inhibitors. Sometimes COX-2 if you're concerned about platelet function in robotic surgery and bleeding, and as well if you have elderly patients that you want to that are concerned about renal function. If not, we use before incision, dose of ketorolac before the thoracic incision, and Decadron, as well as an anti-inflammatory and for post-operative nausea and vomiting. So our whole goal is really honestly to basically block the entire pathway from the brain to the periphery and the ascending pathway. So we abolish the use of opioids, the harmful opioids, and then we use total intravenous anesthesia, no gases. We monitor the depth of anesthesia with the BIS monitor, electroencephalographic activity. We know how deep you're under anesthesia, and we've seen the initial results that patients under total intravenous anesthesia do much better, and do much better because they wake up better. They can tell you the medical record and how they're feeling immediately, less confusion, less fatigue, better recovery. We use infusions of many medications, including propofol, Precedex, but one of the important things that we're using is using a novel long-acting local anesthetic. I already spoke with the CEO. It will be in Europe eventually. It's a bupivacaine, encapsulated bupivacaine. It's in vesicles, and it has the characteristic to be having an initial peak release in 4 to 6 hours and last up to 96 hours. So you have surgeons can inject it in your pores whatever you want, and you don't need to do anything else. This is fascinating, and it has revolutionized our practice. I'll show you what we've done in thoracic surgery, and the FDA has not approved. What we used to do with thoracic epidurals, then obviously we're thinking, Dr. Rice and I, how do we move away from the neuraxial space? A lot of patients now in the United States have stents, drug-eluting stents. They're anticoagulated, so they have contraindication for these blocks. So how do we move from that space? The FDA has not approved Spectral to be injected in the epidural or the paravertebral space, so we kind of invented a posterior intercostal space that has been described before in liver surgery, but never been described in thoracic surgery. And this is, I'll show you what we do. And Dr. Rice is actually doing this perfect block. The line is about 7 centimeters away from the spinous process. You'll see there around there. So Dr. Rice is going to place this under direct vision before incision. He's in the back of this patient. You're almost tenting the pleura, and we've mixed the Exparel with methylene blue so you can see the nice distribution of this block. We already predict that it trickles down to the paravertebral space. So guess what? You have a perfect block like an epidural without having hypotension, without having to deal with problems of patients who are anticoagulated. And to me, what is paramount is that when I see this, I know visually that this patient is not going to require any opioids. It's entirely blocked from T4 through T8, and there's an injection. He uses about 40, dilute this substance that comes in 20 milliliters into 40 milliliters, and use also around the incision port and the chest tube insertion. And you have this almost like a brush painting of this Exparel that is blocking the entire posterior ribs of this patient. They do very well. We recently published this paper in June, posterior intercostal nerve block with liposomal bupivacaine, the first time published about this alternative to thoracic epidural. What we found and what is important is that it's safe, and two, it offers you similar analgesia and pain control than a conventional thoracic epidural. This is going to be revolutionary for our practice. This is very briefly just to show you for these people in administration, at least in the United States and all over the world who are against robotic surgery. This is what we've seen, this paper on minimally invasive thoracic surgery, what happens with potential impact on length of stay and revenue, costs, gross margin per hospital stay, and per hospital room per year in a Medicare patient. We are DRG exempt right now. We would not be at MD Anderson, and this is impressive. When you have a patient that stays 2 days, this is what the hospital gets per bed per year, 2.24, almost $2.5 million compared to what you get to a regular conventional open thoracotomy that takes a week there. This is going to be very important for reimbursement in our already suffocating healthcare system. The other important aspect that we're working on is pneumoperitoneum. This is the puffer fish. As you know, it swallows water and air to appear threatening to its predators, and tolerates the hemodynamic changes very well, assume, but we don't do that very well under insufflation. So we don't tolerate, and mainly in the thoracic cavity, when there's insufflation of CO2, there's a tremendous risk of cardiovascular collapse. The inferior vena cava, the superior vena cava, the pulmonary veins collapse, and we see tremendous drop in the blood pressure. What we're doing, what we found, Dr. Rice has been using AirSeal. I found this extremely beneficial for our patients. I have not seen any because it maintains a regular constant pressure recirculating this CO2. You can use less pressures, and surgeons have better visibility in the console. And we have been able to, because you don't see these peaks and valleys, we've been able to see less hemodynamic and pulmonary compromise. I think this is going to be important. We're already working on a protocol, and this is already approved. We're going to start in about a month. Single center, prospective randomized control study to evaluate shoulder pain, cardiovascular changes, pulmonary pressures, and perioperative outcomes. We'll be looking also at surgeon visibility and tissue trauma. We believe that the trauma to the tissues where you're working is much less. We're going to look at inflammatory mediators. This is important. I think for anesthesia it's going to be great, because then your anesthesiologists in the world are not going to cancel your cases for a robotic urologic procedure, or because the patient cannot tolerate, and this is what I want. I'm excited about making sure that now patients can tolerate easily in trendelenburg position, or even obese patients with COPD. For us it's very important, emphysema patients as well. And then to finalize, I want to just share with you where I believe is the future. Just as you guys are doing robotic microsurgery, I think we as anesthesiologists need to become more visionaries and see where to put the money into. And I think I need to start working, and I'm started already working on looking at the microcirculation where you're working too, so we can be at the same level of knowledge of what's happening at the tissue. This is one of the technologies that I'm interested in, real-time full field laser Doppler imaging. You can see blood flow through a spectral contrast and the Doppler principles. This is an example of an ALT harvest flap to cover a very important defect on a right foot in a kid. Within 30 seconds after revascularization, you can see the blood flow immediately in the center of that flap from the perforator vessels. Imagine the importance of this technology for a plastic surgeon, because in this case it doesn't work, it's amputation. So imagine you having early detection of these complications intraoperatively and being able to correct and improve your surgical outcomes. This is fascinating to me. This is a group from Switzerland who have been working on that. Perhaps Georges knows the group from the Lausanne Institute. The other technology is orthogonal polarization spectral imaging. This is the emission of these handheld devices, the emission of polarized light, and the deep tissues reflect depolarized light, and then obviously transilluminates your entire superficial tissues. So you as plastic surgeons and as thoracic surgeons can see the mucosa and all of the other tissues very quickly. And last, to finalize, real intraoperative pulse oximetry, where you can see exactly where to do the anastomosis, where is the best oxygenation and best healing conditions for the patient. And an image is obviously worth more than 1,000 words. This is one of our patients after robotic lobectomy, the next day riding a bicycle with a chest tube. That tells you that we're doing something right. This is not pure coincidence. It's a real strong synchronized work between the surgeons and the anesthesiologists, because our main goal is to always deliver unparalleled care at our institution. Thank you.